if we want to eliminate the virus, we should identify everybody who is positive and place that person on treatment and ensure that people take preventive measures while they're having, in sexual relationships. And you will notice that you don't see too much of jingles in the air about HIV again, like it used to be. So awareness about HIV is beginning. People are beginning to forget that there is HIV and that people need to be cautious. And I think that definitely is affecting the uptake of services. The other thing is that that one person that you miss out in the community because you are now doing targeted testing is also a human being, and is also somebody that needs to be on treatment. And I believe that every Nigerian should avail himself to be treated. But where you cannot be tested, because we are now focusing the testing only in particular populations, then it becomes a challenge to get somebody that is out there. The ideal thing is that every Nigerian living everywhere should know his status, and then those who are positive should be able to take action on that positivity. But where that is not feasible, it becomes a challenge, and I think that's where it affects the program. For Nigeria, what PEPFAR has done is to put Nigeria on what one may call a waiting list pending a verification of the actual burden of the disease. So right now, the US government has funded the University of Maryland and other partners with the guidance, under the guidance of the Nigerian government, to carry out a surveillance. You would hear jingles about what is called NAIS, Nigerian AIDS Indicator Survey. This is the largest survey globally to be carried out, and the purpose of this is the US government wants to support Nigeria to know what is the actual burden of disease. If we say that we have 3 million people living with the virus, is that really true? We've been basing our estimates on antenatal surveys, meaning that women that come into antenatal clinic, we test them, and those that are found positive against the population, we say, here is the prevalence of HIV. We've done a general population survey that was not big enough for us to generalize, and therefore we couldn't use that data. So now, for example, we assume that in FCT, we will get a prevalence of about 5%, 7%. But we go to the community and do door-to-door testing and discover that within the community we are getting a prevalence of less than 1%. So truly, are we using the right estimates to now budget and to plan? And so Nigeria has been placed on that sustainability sustenance mode, in the sense that continue to sustain what you are doing with a minimal outreach until we know the actual burden of disease. Assuming that the results show that the prevalence is not as high as what we had thought, then it only means then that the amount of money that we will need to respond to this will not be that high. It means then that we can easily now say that, hey, look, we as a country should be able to now say, here is our burden of disease, here is the gap, and here is what we can do. It will enable both funding agencies and government to know exactly how to mobilize resources for the gap that is still there. And I think whether the prevalence shows high or low, it's an extremely important tool for us to use in planning properly. We as Nigerians, Nigerians must take responsibility for our own health. What is the budget of health, and what is the budget allocated to HIV/AIDS, TB and malaria in the federal budget? Is it adequate? Are we putting our priorities right? We do know that Nigeria is still a construction factory village where we are still trying to do roads, we are still trying to build hospitals, but we do know that Nigeria also would be able to allocate more resources than what it is allocating to the health sector, and that should be done. It means then that the federal must allocate to HIV/AIDS what will take care of the problem. The state must do the same, and the local government. The Health Act also would have made provision for taking care of basic amenities. For example, we do not have any reason why a pregnant woman that should receive free pregnancy tests and antenatal will not get free HIV services as far as she is positive. The other major source of funding should be the insurance scheme. I do not see any reason why, if my employees, for example, are on health insurance, why would HIV/AIDS be excluded? HIV/AIDS now is a chronic disease and therefore is not terminal, and therefore it means then that even though there isn't a treatment, a cure, but there is treatment, and my staff should be able to avail of that. Will the National Health Insurance Scheme come up very urgently with a plan to take over the insurance and provide insurance for Nigerians covering HIV/AIDS? The earlier it is done, the better. So that if we have community health insurance, this community health insurance, it covers, the premium covers for HIV/AIDS, and eventually will cover plus cost of drugs. So that if donors now come to say that we're not providing the drugs are not as expensive as they used to be, then the insurance will be able to pick up that bill. Just like it picks up my bill if I take my antihypertensive drugs. Why shouldn't it take care of that? So I believe that a combination of those will take care of the majority, while we have the private sector. The private sector would be able to also now make provision for HIV/AIDS, especially the private not-for-profit, faith-based institutions, etc. So I think that the resources to take care of our problem is here in this country. And the resources coming from PEPFAR and Global Fund should be only gap filling. Meaning then that the technical support we need to do it right, and the fact that treatment is evolving, so we need continuous technical support to do it right, so that our people get the same kind of quality treatment that you get in the United States or in Russia or in Saudi Arabia. Wherever you have quality health care, our people should get the same, and we have the resources to be able to do that if we combine all of this.